Hello, I am Martin Lederman, co-founder of the organization One World, One Vision. Over a decade ago, my associate and I, while on a surgical mission to Belize, founded One World, One Vision in order to train local ophthalmologists and, by doing this, extend our reach. We were successful, and since then, our organization has gone to multiple countries and have demonstrated the success of our ideas. We added anesthesiologists and pediatric intensivists to the mission in order to train local physicians and make the surgical experience of our patients safer. Since then, we have realized that the paradigm of one patient, one student, and one surgeon, while successful, could not begin to address the need. There are tens of millions of children and adults with strabismus and amblyopia. We decided, therefore, to support and to promote a video course in strabismus and amblyopia and approached Dr. Bert Kushner to develop a curriculum and to recruit worldwide experts to give lectures. We stipulated that the course should be translated into multiple languages and to be distributed without cost around the world to eye surgeons. We are particularly grateful to our former patients and friends who have given the financial support to make our dream a reality. We are delighted that Dr. Kushner has accepted the challenge, and we hope you find the lectures both stimulating and educational, and that you share them with your colleagues and your students. And so, without further ado, I give you Dr. Bert Kushner.
Welcome, viewers. I'm Dr. Burton Kushner, and I'm the moderator of this One World, One Vision comprehensive course on strabismus and today's lecture on amblyopia. If you're new to this series, I'm glad you're checking it out. If you're a former viewer, I'm delighted that you're back. Today, I am so pleased to introduce our speaker, Dr. Yasmin Bradfield, from the Department of Ophthalmology and Visual Sciences at the University of Wisconsin. Dr. Bradfield is the John Doolitle Professor in the Department of Ophthalmology and Visual Sciences, and I will say she's a close colleague of mine. She's a leading investigator for PEDIG clinical trials. She's actually been in 24 clinical trials, 13 of which as principal investigator, many of which dealing with amblyopia. She's on the board she is on the AAPOS board of directors and serves as co-chair of the Department of Ophthalmology and Visual Sciences Global Ophthalmology Initiative, where she develops international resident and faculty exchanges and is developing a global ophthalmology curriculum to become implemented by residency programs nationwide. As of July of this year, she will be the program director and chair the national and international pediatric ophthalmology meetings for AAPOS and the AAO. And her being appointed to this position, I think, is a real testimony of the high regard that her colleagues have for her. Dr. Bradfield's published 45 articles, 5 textbook chapters, and given 148 clinical presentations. I consider her an astute and knowledgeable clinician and clinician scientist, blending the best of both worlds.
Thank you, Bert, for including me in this wonderful project. Today, I'm going to give an overview of amblyopia. What is amblyopia? It's the most common cause of visual impairment in children, occurring in up to 4% of the population. There is an increased prevalence in those with a family history of amblyopia, children who are born prematurely or with developmental delay. So what is the cause? It is thought to be a binocular phenomenon due to suppression or reduced image into the visual cortex of one eye, which may or may not be due to abnormal input to the visual cortex. It is often clinically defined as a difference in best corrected visual acuity of 2 or more lines, or if using isolated optotypes, which is easier for amblyopia patients to see, a 1-line difference. It is also defined as fixation in either preverbal children or children with developmental delay that is not maintained. There are different forms of amblyopia, including ametropic amblyopia, which is due to typically symmetric high refractive error, which has been uncorrected, and anisometropic amblyopia, which is unequal refractive error between the two eyes, deprivation amblyopia, which tends to lead to the densest forms of amblyopia, which is due to the lack of visual stimulation that leads to abnormalities in the development of the visual cortex, occlusion amblyopia, which is iatrogenic, induced by either patching or atropine treatment, and strabismic amblyopia, in which the misalignment of the eye leads to active suppression of the eye that is tropic. Ametropic amblyopia occurs with typically equal bilateral visual loss. It's caused by equally high refractive errors between the two eyes, and you can see that you need a lot higher amount of myopia in children to induce this amblyopia because it's easier for them to see up close than far away. Also, high amounts of hyperopia and astigmatism. The longer that these refractive errors go uncorrected or undetected, the harder it will be for these eyes to have normal vision. Often, visual acuity improves simply by wearing glasses for a long period of time. However, in these children, the potential of reaching 20/20 vision is unlikely, particularly if they don't receive glasses until the age of 3 or older. Anisometropic amblyopia is the most common form of amblyopia, and this is caused by unequal refractive errors between the two eyes. And you can see the differences needed to cause this amblyopia. However, it is important to note that some patients may have less of these amounts of anisometropia and still develop amblyopia. There is a risk for amblyopia because of the ability of the brain to actively inhibit the vision of the blurrier eye. By doing this, the eye does not receive proper visual stimulation and therefore does not develop normal vision compared to the other eye. Deprivation amblyopia develops because of lack of visual stimulation from the retina to the visual cortex. Often, there is something that interferes with the visual pathway, such as a congenital cataract, a corneal opacity, or ptosis. One thing to note with ptosis, unless it is full, complete ptosis covering the pupil, the majority of amblyopia that stems from congenital ptosis is actually anisometropic amblyopia, which is induced by astigmatism when the lid sits on the cornea. With deprivation amblyopia, if this is left undetected and not improved, the amblyopia can be dense and potentially irreversible. Strabismic amblyopia is due to suppression of the deviated eye, which leads to cortical inhibition. We are more likely to see this in patients with an esodeviation rather than an exodeviation, and the reason for this is that exotropia at onset tends to be intermittent at first, allowing the eye that is deviating to still develop vision. With esotropia, the fovea of the eye that is misaligned has to compete with the strong temporal hemifield of the fellow eye, leading to amblyopia. The likelihood of having amblyopia is much greater if there is a constant deviation rather than intermittent. And vertical deviation, such as in patients with congenital supraoblique palsy, may not be as amblyogenic if patients are able to adopt a head posture to maintain good alignment and fusion. There are milestones in visual development that we should all know about. At birth, there should be a response to OK drum. At 1 month, often parents will notice that their infant is able to fixate on their face. At 2 to 3 months, the infant is able to smile with foveal fixation and even follow a moving target. Around this time, convergence develops. Between 3 to 6 months, stereopsis develops, but it's not until around 1 year of age where an infant's vision achieves 20/20 vision. The American Association for Pediatric Ophthalmology and Strabismus have used evidence-based guidelines in order to detect children who may be at risk for amblyopia due to refractive errors. You could see here that younger children, specifically children under the age of 4 years old, can tolerate a higher amount of astigmatism and myopia that is uncorrected and not lead to amblyopia. However, we know that amblyopia treatment is better with better vision outcomes if caught and treated earlier. So with pediatricians and family practitioners who have access to a photo screener, they often will utilize a photo screener and use these criteria to know when to refer patients at risk for amblyopia to a pediatric ophthalmologist to do a full eye exam with cycloplegic refraction. Vision screening can occur in multiple locations, typically in primary care offices, such as with pediatricians or family practitioners, even in schools, in which typically a school nurse will perform a vision screen, or outside organizations will volunteer to perform these in various schools, as well as daycare. The techniques vary and really are dependent on the patient's age. There is the Bruckner or red reflex testing that is performed in infants and young children, in which typically a direct ophthalmoscope is used to look at any asymmetry between the red reflexes of a child's eye. There is the corneal light reflex, which is very helpful in detecting strabismus. Photo screening, as we just talked about, can also show differences in red reflexes, refractive error, and detect strabismus. This is usually done in a pediatrician's office. There is subjective vision testing, which we think is the gold standard, in which a child will identify either letters or pictures. There is stereopsis testing, as well as use of an autorefractor. The caveat with the autorefractor is it should not be used in infants and young children, as they have a strong ability to accommodate, and any hyperopia or farsightedness will go undetected if using an autorefractor. The evaluation of amblyopia includes assessing visual acuity as well as fixation. The age of the patient really determines which test to use, and we know that we should use the most rigorous test the patient is able to do. And the reason I say that is that a child who's able to do pictures, such as Allen pictures, and may have a vision of 20/30, which seems normal, may not have that same vision when doing Snellen acuity. In fact, the vision may be reduced to 20/40 or 20/50, which is amblyopic. So I have a low threshold for patients that perform a borderline vision test to bring them back and have them repeat the vision test and try to get them to do the more rigorous test, often sending them home with the pictures or letters that we will be testing them with in clinic so they become familiar with the test. Assessing vision and fixation can also be limited by patient cooperation. There are many steps to the clinical exam in detecting amblyopia. There is fixation assessment, using a binocular fixation pattern to see if the patient has central, steady, in other words, without any nystagmus, and maintained fixation. One easy test that is very useful is called the induced tropia test. This is a test in which a vertical prism is placed over either eye of the patient and using a corneal light reflex to detect which eye the patient is fixing with. If it is always with the same eye, despite where the prism is placed over, the patient likely has amblyopia. There is the eye popping reflex, which occurs at a very young age at the first 3 weeks of life, in which a dramatic change in illumination, typically the room lights are dimmed suddenly, the infant will have a widening of their eyes because they have detected this light. So you can actually tell if an infant has light perception based on this eye popping reflex. There's also aversion and a blinking to light or threat of an object coming quickly towards an infant's face. Preferential looking has a role in young preverbal children with amblyopia using either teller acuity cards or petals, as you could see here in the upper right picture, with the vertical stripes on one paddle and nothing on the other paddle. And the concept is based on that the child will have a preference for looking at the paddle with the stripes versus the paddle with nothing if they can see the stripes. As the stripes get thinner and thinner, the child will either look at the stripes or not look at the stripes, and a numerical value of vision can be given after this test. It is very useful in children who are pre-verbal. The visual evoked potential test is a very sophisticated test that quantifies the function of the entire visual pathway, including the retina, optic nerve, and visual cortex. I find that it is very useful to do this test in infants and young children who I'm either trying to decide if they need glasses or treat for a structural abnormality such as a tiny cataract. Also, serial VEP testing is helpful to determine if there is visual improvement over time in a patient that I am prescribing patching treatment for. The downside of this is that it does require expensive equipment, space, and typically a trained electrophysiologist to perform the test in clinic. The clinical exam often will include visual acuity testing, which is subjective if a child is old enough to perform this test. This will include optotype letters and pictures and should be in a linear or blocked manner, although isolated testing can also be performed. It is important to understand the crowding phenomenon when doing visual acuity testing in children with amblyopia. This is a phenomenon in which with normal children, there's lateral inhibition of letters or pictures if they are placed in a linear line or with blocking lines around the optotype. As the letters or pictures get smaller, it is harder to determine individual optotypes in that line. So therefore, if you show an amblyopic child an isolated letter, it is much easier for them to identify this letter because the crowding phenomenon is exaggerated in patients with amblyopia. So if you only do isolated pictures or letters to assess vision in amblyopic children, you may be overestimating their vision. Linear or blocked optotypes should be used. In nystagmus, it is important to note that translucent occluders or fogging lens, such as a high plus lens, should be used to test vision, because if you use a black occluder or a solid occluder, it may increase latent nystagmus in these children and artificially decrease the vision that they can provide. Near acuity should also be tested. I always like to test a child's near acuity because some patients may have hypoaccommodation and have worse vision at near than distance. Of course, every child who you're trying to detect or rule out amblyopia should have a complete dilated eye examination, including a pupillary examination to check for an afferent pupillary defect. Even with the densest forms of amblyopia, it is rare to see an afferent pupillary defect. So if you see one in a child with reduced vision, you should be looking for another cause for the reduced vision. There are various ways to treat amblyopia, and this includes optical management or the wear of glasses, patching, penalization, typically with atropine eye drops, the Bangurter filter, as well as the newer binocular dichoptic treatment. What we all know is that if a child needs glasses, that's what they need to get first. They have to be put in glasses to correct the refractive error before any other forms of treatment is given. The reason I say this is because there are some forms of amblyopia that are completely resolved with just a glasses correction, typically anisometropic amblyopia. So we want to understand what a child's baseline vision is before we start other forms of treatment. If a child has a prescription for glasses that they need to be in, they should get that first and return in about 2 months to assess where their new baseline vision is. There is occlusion, which includes adhesive patching, felt, or even a pirate patch over the dominant eye. My preference is the adhesive patching if a child can comply with this. And the reason for that is that then there is no peaking, especially around the nasal quadrant of a felt or pirate patch. However, there are some children, such as children with sensory aversion, that may not like to have an occlusive sticky patch over their face. and you may have to default to another form of treatment. There is a question of whether full-time or part-time patching should be offered, and this really, in my mind, depends on a child's age and the density of their amblyopia. There is occlusion contact lens as well, which probably is used in a very small percent of children due to difficulties of applying a contact lens in a child. Also, there can be partial forms of occlusion, such as a Bangirder filter or frosted tape, which still allows for some visual stimulation of the dominant eye. However, with forms of occlusion treatment, such as patching, compliance is a problem. And in some studies, less than 50% of patients actually will comply with the hours of patching that is prescribed. Penalization can occur with either pharmacologic penalization or refractive. Atropine eye drops or ointment can be used daily in the dominant eye to produce blur of the near vision. I typically use this in patients in which I think may not be a candidate for patching, or we've tried patching and the compliance is poor. I like to use it in patients if they have a high amount of hyperopia in their fellow non-amblyopic eye to help with the atropine drop to work to blur the near vision. Refractive penalization can occur by adding a high plus lens to the dominant eye to cause a distance blur. This can cause headaches, though, and may interfere with schoolwork, so this needs to be tailored for the child. This can be combined with atropine for total penalization. The Pediatric Eye Disease Investigator Group is a network of academic practices and private practices across the United States and Canada, which have performed several randomized prospective clinical trials in children with eye diseases, with many of the trials focusing on amblyopia. The landmark study was performed looking at children with moderate amblyopia and randomizing children to either daily atropine treatment or 6 hours a day of patching. It was found that both were well tolerated, and although there was an initial increase in vision that was faster in the patching group, similar results were noted 6 months later in both groups. Atropine, however, did receive a better score on the parent questionnaire in terms of better compliance and social stigma of patching. PEDIG also looked at children with moderate amblyopia and determined that 2 hours versus 6 hours of patching in their study did not seem to show a difference in the final vision improvement. Also, they performed a study in children with severe amblyopia, and it was noted that full-time versus 6 hours of patching showed similar vision improvement. They also studied levodopa, which did not appear to have a role in amblyopia treatment, with minimal improvement of vision that was not sustained. Other PEDIG findings include that there is a high rate of amblyopia recurrence within the first year of stopping treatment. Up to a quarter of patients will have recurrence. And if patients are doing 6 hours or more daily patching, it is better to actually taper them off the patch in small increments. For instance, going from 6 hours to 4 hours for a few months, then 2 hours for a few months before discontinuing the patch, to try to decrease the risk for recurrence. Patching, interestingly, was found to be successful even in older children. Children the age of 13 to 17-year-old who had not previously been patched for amblyopia did have vision improvement with part-time patching. The caveat for that study is that there was an average of 2 lines of vision improvement. And this is important because when I see patients who are older with amblyopia who've never had any patching treatment, I talk to parents about whether we should try this in their children to try to improve their vision. The 2-line improvement is important because in children, for instance, with 20/200 vision, an improvement of 2 lines may not allow them to have a great functional benefit. However, if they have 20/60 vision in their amblyopic eye, a 2-line improvement to get them to 20/40 in the United States gives them an unrestricted driver's license if that's their only seeing eye. It's good to achieve that level of vision and a spare eye. And in those patients, I will encourage parents to see if we can start amblyopia treatment despite their older age. PEDIG studies have also looked at whether near activities enhanced patching vision outcomes, and it showed that it did not. And atropine use on the weekends rather than daily showed vision improvement at a similar rate. There are helpful tips for amblyopia treatment that I like to offer to parents and families. You want to try to tailor the best treatment for best compliance in patients and families. For instance, if you know that a child is very busy and is unlikely to comply with patching, you may want to discuss using atropine instead. Also, in patients that may have sensory aversion to having a sticky patch on their face, maybe try a felt patch or atropine eye drops. You want to be flexible and understanding with patients and parents. I often have families that come in and they say that, I know that you had told us that our child needed to do 6 hours a day of patching, but we've only been able to get 2 to 3 hours. You want to understand the limitations that families have and how to work with them to ensure better compliance. Sometimes it's really just education of why this is important. Other times it's finding another modality of treatment or combinations of treatment to help with vision improvement. For patching, we're fortunate at our institution to have excellent, experienced orthoptists that will provide education and show parents how to apply the patch properly so the child does not peek around the patch. I often think that it's easier to reduce patching after a child has done several months of patching than to start at a lower rate and then tell them to go from 2 hours, for instance, to 6 hours. Follow-up visits should be determined by the age of the child and the amount of patching that they're doing. For full-time patching, the rule of thumb is you want to bring a child back for every week per year of age. So for a 3-year-old that you are starting full-time patching, they need to come back in 3 weeks to ensure that you are not causing occlusion amblyopia of their fellow eye. One thing I always discuss with parents is that the child's brain will determine whether 20/20 vision may be attainable. So I feel that it's important for them to understand this right off the bat so that they are not disappointed even if they have done all of the patching or atropine treatment that you have asked them to do and their child still does not reach 20/20 vision. Other things that I think about with atropine is that in general, it blurs a patient to 2100 vision. So if you have a patient with worse vision than 2100 in their amblyopic eye, you may not get them to have vision improvement if the vision in their fellow eye does not blur beyond the level of 2100. You also want to watch for a fixation switch at near in the clinic to see if the atropine is working. Interestingly, PEDIG studies have showed, even in patients with severe amblyopia, in which a fixation switch was not detected during the follow-up clinic exams, that it still can improve vision. This can be a useful alternative to patching if patching has failed or there's non-compliance. One thing to understand is that strabismus can appear after amblyopia treatment. So in patients that may have an accommodative esotropia, you don't want to reduce their hyperopic prescription because when you do that and then you introduce patching, which breaks down their binocularity, this can cause an esotropia that parents will then blame the patching for. So you want to make sure that they are in their full prescription before you start patching treatment. You want to stress the importance of full-time glasses wear and also be supportive in developing reward systems. One of our orthoptists likes to talk about how she recommends parents to talk to the teachers of the child's school and to involve other classmates and have the child bring in blank patches and that children can actually draw or color on a patch. And every day when a child wears a different patch, their classmates will be proud and say, "Hey, you're wearing my patch today," just to provide some positive reinforcement to the child. There are a lot of ways to reward a child for patching or using atropine or for other forms of amblyopia treatment. And it's really important to have this discussion with families when you're introducing amblyopia treatment. We're going to switch gears and talk about binocular amblyopia therapy. There has been an interest in developing an alternate treatment for amblyopia with potentially better compliance as well as visual outcomes. This concept, which was first described by Dr. Robert Hess and Ben Thompson and colleagues at the McGill University, is a concept that relies on giving different visual stimulus to each eye in a patient with amblyopia to reduce their binocular or interocular suppression. This group and other groups were interested initially in adult studies. So adult patients with amblyopia performed custom-made dichoptic or binocular video games in which the visual input was separate in each eye. It was noted in those studies that this could overcome suppression and allow patients to use binocular vision, including improving stereopsis, and contrast sensitivity was also improved. The long-term results of these studies in adults were mixed. However, this concept was adopted by Eileen Birch and her group at the University of Texas, in which she wanted to study children with amblyopia performing these custom-made video games using glasses that would provide different inputs in which the amblyopic eye received a higher contrast with better resolution view of the video game versus the fellow eye. This is a game, as you can see on the right, is Tetris with falling blocks. And she had other games as well for this study. And this was a pilot study that she performed, which actually, if you look at the results, the overall results are these 3 bars on the left. She did show that within a very quick span of 4 weeks, patients who used the binocular game were able to get a 1 to 1.5 lines of vision improvement versus those who are not compliant with the treatment. So those in the second bar you could see here did not play the binocular game or a sham treatment. You can also see with the bars on the right side that the children who played the binocular games and added part-time patching at other times of the day did not seem to have an improvement of their vision versus playing the game alone. Patients who only did patching part-time and decided not to play the game also did not have any further improvement of their vision. This was an exciting finding that binocular treatment may actually improve vision in children with amblyopia. Other studies were then performed. One of the things that was noted in this study was that compliance with repetitive gameplay was low. So her same group created dichoptic movies to try to improve compliance, in which children would actually watch movies in which they wanted to watch. These were popular movies for young children, and they would wear glasses in which you could see here on the left, this is what the amblyopic eye would see through the glasses, some areas of high contrast for the movie, and then there were some of these blobs that would actually disrupt part of the viewing. The fellow eye would actually have a blurred or dimmer viewing using the glasses, but both eyes had to work together to view the entire movie. This definitely showed better compliance in children. They liked watching movies instead of playing repetitive games. They did not get bored with the number of movies that they were allowed to watch. So this did help with final visual improvement with a long-term treatment. There have been 2 recent FDA-approved devices that are exciting alternatives to traditional treatment. Luminopia is the first one, and this was studied in a prospective multi-center randomized trial which compared visual outcomes using a binocular virtual reality headset that was used at home in children who also wore their glasses versus children who received glasses alone. Over 100 children, the age of 4 to 7 years of age, with anisometropic amblyopia or small angle strabismus, so angles of strabismus 5 prism diopters or less, were enrolled in this study. The binocular treatment was prescribed for 1 hour per day, 6 days a week, with the visual outcome measured at 12 weeks. There was proprietary software which could modify popular TV shows, and these were numerous shows, videos, movies, to allow for increased compliance using this device, which also lowered the contrast in the fellow eye. What they found was at 12 weeks, there was a difference with the mean vision improvement in 1.8 lines with the binocular treatment versus less than a line in the children with glasses alone. So this was effective at 12 weeks in improving vision in the children who use the binocular dichoptic therapy. You can see the very high compliance rate using the VR headset with no serious adverse effects such as headaches, double vision, reduced vision, as well as eye strain. The one thing to note in this study is that the vast majority of patients in the treatment group had prior patching or atropine treatment with a vision that had plateaued. So this is an exciting finding and may provide another treatment for children who have already undergone amblyopia therapy, but had a plateau in vision and did not reach vision of 20/20. The question is whether this could improve their vision even further using binocular treatment. As you can see in this graph here on the left, that even as early as 4 weeks, there was a difference in the vision improvement in the patients who used Luminopia binocular treatment versus those who just continued glasses. And if you look at the last bars on the right at 12 weeks, there was a significant difference in the vision improvement between the two groups. The other device, CureSight, is also FDA approved, and this was studied in a prospective, multi-center randomized trial, which compared the vision outcomes after use of a new technology which featured eye tracking. And this was a home-based binocular treatment in children versus children who just underwent patching treatment for amblyopia. There was a similar number of children enrolled in this study, over 100 children, with a higher amount actually of kids who are older. So this did include children even 7 to 9 years of age with anisometropic, small angle strabismus, or mixed mechanism amblyopia. The caveat for this is about 90% of children enrolled in this study had anisometropia. The binocular treatment was prescribed using glasses, which allowed for different inputs to each eye, with the new technology of an eye tracker to induce blur around the fellow eye fovea in dichoptic stream videos. So again, these were videos that children liked to watch. They were movies or other forms of video content, which were popular and improved compliance in children. As you can see here, that the patching group did almost double the amount of treatment hours compared to the patients that received the CureSight binocular treatment. This is what it looks like to do this treatment. So you can see that with the glasses giving separate images between the two eyes, you can see in the lower blue picture here, this is what the amblyopic eye would see watching a movie. And then the upper pictures, which were red, shows how the color was different and saturated in the fellow eye. And then there is a foveal blur. And the interesting thing about this study and device was that the patients with worse amblyopic eye distance acuity, as well as greater interocular differences in vision, were able to get greater amplitudes and diameters of the foveal blur in these glasses. So this was really tailored and prescribed for individual patients. It was customized in a way to try to improve vision in patients with denser amblyopia and also greater differences in vision. The eye tracking technology was very helpful to detect at a remote center whether a child was really fixing on the movie or not. And in fact, the treatment time was paused if it was noted that a child was not watching the movie with the eye tracking device. The mean improvement at 16 weeks from baseline were similar in the patients who received this CureSight binocular treatment versus those that just received patching. There was no significant difference in the improvement in the two groups with stereo acuity or binocular vision, which were both improved. However, the binocular treatment had higher adherence rates than the patching group with no serious adverse effects. You could see here, if you look at the bars on the very right of this graph, that at 16 weeks, there was further improvement of vision. And these were measures of patients that had at least 2 lines of improvement of vision or more, that there was further improvement at 16 weeks in the binocular treatment arm of this study versus those with patching. If you look at those with patching only, there's no significant difference in the number of improved vision of 2 or more lines between the 12 and 16 weeks. So there is potential further vision improvement with this treatment with a longer duration of treatment. And this really needs to be studied, but this is an exciting alternative to traditional treatment. In general, binocular amblyopia treatment does have a few limitations. This is not applicable to children with larger strabismus. At least it has not been studied yet in those patient groups. There is the questionable availability as well as the higher cost of this device, particularly in developing countries. In the United States, there still is varying insurance coverage and reimbursement for applying this device in children with amblyopia. Overall, in conclusion, there are many forms of amblyopia and treatment varies depending on the type of amblyopia a child has. There are multiple tools for vision assessment, which differs by patient age, development, and cooperation. Amblyopia can be treated successfully, but there is definitely lower success rate that occurs if children are caught too late, so they are older, as well as with deprivation amblyopia. This is why it is very important to find ways to detect amblyopia at the youngest age possible and to start amblyopia treatment at a very young age. There is exciting, newer binocular dichoptic treatments that can provide an alternative to traditional treatment, and this needs to be further studied. Lastly, I want to thank 2 of the orthoptists that I work with, wonderful colleagues at the University of Wisconsin, Callie Lohberger and Leslie France, who shared some of their slides with me in this presentation. And here are my references. Thank you.
Thank you, Dr. Bradfield. That was wonderful. It was thorough, comprehensive, and I'm sure it'll give everybody some important tools and pointers for treating patients with amblyopia. I do have just a couple of questions, but first I'd like to kind of share an anecdote, if I may. We typically use visual acuity, Snellen acuity, as our outcome determination, and that doesn't fully describe the whole visual experience. Not all patients with 2200, for example, are having the same visual experience depending on the cause of the vision deficit. And I have been told, in fact, by patients that amblyopia is perhaps one of the worst or more debilitating causes of vision loss. One patient described it as though when looking with his amblyopic eye, he experienced things similar to when you see heat rising off a highway, sort of a shimmering effect. And parts of the Snellen letter will fade in and fade out. There's sort of a kinesis to it, which in part explains the crowding phenomenon. If there's an isolated letter, you can figure it out more easily than if there are other ones similarly in motion adjacent to it. Well, I had this one patient, I remember a number of years ago. It was a woman in her 60s. She had a large angle strabismus and an amblyopic eye that was about 20/50, maybe 20/60. And she developed a spontaneous macular hole in her good eye. So she was 2200 in her formerly dominant eye, 20/50 or 60 in her amblyopic eye. And she continued to fix with the eye that was 2200. And I asked her, why do you use your left eye? You see so much better in the right eye, the amblyopic eye. And she said, I can't see out my right eye, that just really stayed in my brain. So that's the anecdote. Just a couple of questions. You properly emphasize the need for cycloplegia with refracting patients, when refracting patients with amblyopia. What are your choice of cycloplegic agents in younger infants, younger patients, and if you're dealing with a patient with a dark brown iris? Are tropicamide ever adequate for young patients? What are your choices?
So, to answer that question, the answer is no. Tropicamide does not provide cycloplegia in patients. For younger patients, so for instance, infants that are 12 months or 20 pounds or less than 20 pounds, what I like to use is what's called cyclomidrol. It can also be created, but it's 0.2% of cyclopentolate with 1% of phenylephrine. And that has been found to be safe. I usually do like to use punctal occlusion in infants just to make sure they don't have systemic effects, which can lead to decreased heart rate with the cyclopentolate specifically. But that is what I typically like to use in infants who are under 20 pounds. Once they're older or they're over 20 pounds, I do like to use 1% cyclopentolate because that does provide adequate cycloplegic paralysis to their ciliary body. And the issue with not using cyclopentolate and using, for instance, tropicamide, even a combination of tropicamide and phenylephrine, is that you will get the pupillary dilation, but you won't get that temporary paralysis of the ciliary body. And then this will mask hyperopia in children, so that you may be prescribing glasses or not prescribing glasses because you don't know that they're really hyperopic. Yeah. The patients with darker eyes, with brown eyes, I do like to add phenylephrine or tropicamide to the 1% or even 2% cyclopentolate, depending on if there's availability of the 2% formulation.
Great, thank you. And just if you don't mind speculating, move the clock ahead 20 years, 50 years, whatever, what do you think the future will be? What do you think the role of dichoptic treatment will be in our day-to-day armamentarium? Forgetting the issue of insurance coverage and so on, just from the science point of view.
Well, this is so exciting because literally 10 years ago, we were talking about, is this even a possibility to use in children as it was being studied in adults? Now we have 2 FDA-approved devices, which can show us that binocular treatment works. And the question is whether in 5 years' time, 10 years' time, children can actually do this at home, maybe even on a cell phone or on a computer or iPad device where they're just doing this at home, watching whatever movie they want, watching TV, whether or not they need a pair of glasses. Maybe the technology will improve so that you have channels, amblyopia binocular treatment channels at home that parents can subscribe to, which treat amblyopia with better compliance. What we really need are better ways of treating amblyopia with better compliance, because the patching treatments and atropine treatments really fall short. And we all know this. Those of us who have been practicing for years know that whatever you tell parents to do, often it's not done at home. And, because of a variety of reasons. It could be that the child just won't comply with it. The parents are busy. They have other kids. The child has sensory issues or delays. These types of binocular treatment, which can be used at home and monitored remotely, are really a breakthrough in how we might be able to treat amblyopia in the near future, maybe not 10 years, maybe 5 years. So it's an exciting addition to our toolbox of amblyopia treatment, and hopefully the technology will just keep getting better.
That's wonderful. So certainly something we can all look forward to. So Dr. Bradfield, again, I'd like to thank you for your time and your expertise. Viewers, I'd like to thank you all for your attention in tuning in. If you enjoyed this, I hope you tune into the other lectures in this series. And with that, I'll say until we meet again.
In bringing you this video course, there are many thank yous. Thank you for viewing the video course on strabismus. We hope you found it stimulating and educational, and that you share its insight with others. We at One World, One Vision extend our heartfelt thanks to the lecturers who shared their years of study to make the video course worthwhile. And of course, to Bert Kushner for taking on the burden, happily we hope, of development and moderating. We also thank the Board of Directors for their continued guidance. We thank our donors for their financial support that made this video course possible. An enormous thank you to the video team of Sweet Sadie for their extraordinary efforts to make the course both visually and auditorially, extraordinary. And for their technical guidance of lecturers. Thank you, Rachel, Tim, Eddie, and Bill. If you are interested in learning more about what we do, go to our website, www.oneworldonevision.org. And finally, if you have comments or thoughts or ideas, you can email me at owov2020@gmail.com. Goodbye.